Osteoarthritis is a condition. It's not really a disease. It's a condition where joints wear out. We specialize in hips and knees. These are weight-bearing joints, and they tend to wear out earlier than non-weight-bearing joints and cause symptoms. The symptoms associated with osteoarthritis are stiffness and pain and swelling. And these symptoms, as they deteriorate, affect people's mobility. As we age, mobility becomes critical. It's not a life and death condition, but as mobility decreases, people tend to put on weight, blood pressure goes up, the quality of life diminishes. Then the decision needs to be made as to whether we are able to modify our life and accept the loss of function, or whether we need to do something to improve our quality of life, and what treatment options are available.
Please visit us on www.jointreconstruction.com or call us on 9387 2877.
Here at the Joint Orthopaedic Centre, before we discuss any surgery at all, we look at what other non-surgical options may be available, may be applicable to the individual patient. Options such as weight loss, activity modification, simple things like the use of a walking stick or a walking frame. For many patients, oral medications are not applicable because of the potential side effects. Other possible alternatives, such as cortisone, may or may not be applicable, and we discuss that at length. Surgery is not the first option, but surgery is an option which we consider within the spectrum of the treatment options that are available. After we have a consultation and we discuss the treatment options, then the next question to decide is when is the best time. Now, that's a complicated decision, and it's based really on two factors. The first factor is a medical decision, whether or not the joint is severely affected enough to warrant surgical intervention. And we discuss that with x-rays and scans and MRIs and come to a decision as to whether the joint is severely affected to that point. Then the next decision is timing. Now, timing is an individual thing, and it applies to the individual characteristics and requirements of the patient. We talk about quality of life. Quality of life is a complex thing, and it's a mixture of pain and stiffness and frustration and depression and anger and all of the things that make up the emotional environment when you realize that your capacity to do things is not what it was, it's not what you wish to be, and you are worried about what the future may hold. So for each individual patient, the timing of surgical intervention depends on the quality of life that they wish for themselves and the level of deterioration that they have experienced. As a wise man once said, it's better to be 70 years young than 40 years old. When we deal with osteoarthritis, it's not a fatal condition. It's not going to shorten one's life. It's not going to cause death for any reason. It's a quality of life condition. So if you don't have surgery, nothing will happen. You will stay as you are. Gradually, as the joint wears out, the level of function will diminish. The level of function for an individual is a combination of many joints, and each joint has a limited amount of reserve. And as the joints wear out, the reserve diminishes, and other joints which may be able to compensate for one arthritic joint may not be able to compensate if all the joints are arthritic. So if no surgery is undertaken, you will need to alter your activities and become more sedentary, not as active. Over the last 35 years or so since I've been in practice, my total experience in joint replacements, hips and knees, is of the order of 6,500 over this period of time. We've had a special interest in hip resurfacing surgery, and up until now, our experience with hip resurfacing is of the order of 1,200 joint replacements. I'm happy to say that we have a high success rate. For knee replacements, we have special interest in partial knee replacement, unicompartmental replacements, and up until now we've performed approximately 1,000 of those. Again, I'm happy to say with a high success rate. Our treatment plan for hip surgery is tailored to the patient's requirements. As people have maintained good health well into their 70s and 80s, their activity requirements have increased. No longer are people happy to be sedentary and be satisfied with pain relief alone as a result of the surgery. People generally want to be able to maintain, if not increase, their activity level. For total hip replacements, so dealing with patients, say 65 years and over, we perform total hip replacements generally using ceramic bearings as necessitated by the patient's requirements. And over the last 9 years, we've performed the surgery through an anterior approach, which we've found to be much more user-friendly. The recovery is much faster, pain is much less, and overall patient satisfaction greatly increased. For younger patients, hip resurfacing has been a procedure that we've been performing for the last 16 years. There has been a lot of controversy in relation to hip resurfacings, a lot of controversy in relation to metals, metal ions, and unfortunately some seriously adverse results have been experienced in relation to some particular prostheses. Not all prostheses are the same. The Australian Joint Replacement Registry, which is an excellent piece of in the Australian Joint Replacement Registry, the successes and failures of the various implants are carefully documented, and the implants which we use have a long record of excellent performance. The resurfacings are a particular group of joint replacements, and like all prostheses, they have good and bad factors to consider, and that is something we discuss at the consultation. That aside, a successful hip resurfacing will allow the patient unrestricted activities, and so for young men, particularly active young men, this particular procedure will allow them an almost normal lifestyle. Knee replacement is also a successful operation, but the selection criteria are different to hip replacements. Up until now, our experience with knee replacements over the last 30 years has been of the order of 2,500 implants. Technology has changed a great deal over time, and the materials have improved, surgical techniques have improved, patient selection has improved, anesthesia has improved. The function of total knee replacements and patient satisfaction is excellent, much better now than it was 15 years ago, but it is a joint replacement, and full activities such as running and jumping are probably not realistic. Here at the Joint Orthopaedic Centre, our focus is to try and maintain a practice which is at the forefront of technological advancement. Here at the Joint Orthopaedic Centre, we've focused on trying to stay at the forefront of technology advancement. However, we now know that not all change is progress, and one of the challenges has been to try and determine what changes in technology, what changes in materials, what changes in surgical techniques will benefit our patients, and what changes will not. That takes time and assessment, and over time we have evolved a surgical technique in conjunction with my anaesthetic team where we've been able to minimize the pain, improve mobility, have the patients return to their normal life much earlier than previously possible. In essence, what we try to do is to minimize the hole that the surgical process makes in the patient's life. And we do that with a comprehensive patient education program so that the patients know what to expect, what rate of progress they can anticipate, what pain they can expect to feel. So we try and avoid any surprises. We do that through a complex pain management program which we've published, and I'm happy to say has been taken up in many parts of the world. And the net result has been that the patients can get up and walk within several hours of their operation. Often they can go home after 1 or 2 nights in hospital. Often they can resume their normal activities of daily living within several days. Now, there's significant variability in patients. Some are well when they have surgery, some are not so well, and so we need to modulate this program according to each patient's individual requirements. Here at the Joint Orthopaedic Centre, we have a well-established process to prepare patients for the surgery, minimise anxiety, and optimise their cooperation. It's not something that we do to patients. The surgical process is something that we do together. So the education process is aimed at harnessing the patient's cooperation, harnessing their understanding, so they can help us get them through the process as quickly and as effectively and as painlessly as possible. So we have a consultation where we discuss the underlying problem, the treatment options, and the process for progressing. And the patients have time to think about what we've discussed. Often they come back with a relative, and we have another discussion and address the questions they may have. Then, if the surgical option is adopted, the next step is to have a formal consultation with the anaesthetist. And often patients are more concerned about the anesthesia than they are about the surgery. And so the fear of the anesthetic is something we address before the surgery. And my anaesthetist, Dr. Dennis Kerr, carries out formal consultations in my office with the patients and their relatives to make sure that their concerns are addressed, that their fears are minimized. And we need to remember that over the last 10 years, the improvements in anesthesia have been dramatic. And patients often have misunderstandings about what the anesthetic involves, and often they have fears from previous experiences that we need to address. Then the next step is the hospital admission. And we work at several hospitals depending on patient requirements. Some patients need intensive care facilities or at least availability, but the majority of patients are well when they start the surgical process. And for those patients, we need a hospital where the infection rate is minimal. And for that to be achieved, generally we would choose a hospital without intensive care facilities because sick patients would not be admitted to that area. Then the surgical process is completed and patients are often discharged a day or two after the surgery, as long as they're happy to go home, they're mobile, they feel well in themselves. After surgery, generally the patients feel well and we're happy for them to go home a day or two later. If they need more time in hospital, they can stay as long as they need, but generally, if they're mobile, if they feel well, if they're happy to go home, and if they have a supportive environment at home, then generally the hospital has nothing further to offer them. And so we're happy to discharge them to the comfort of home. Our guidelines for postoperative management for hip and knee surgery are individualized. For hip surgery, most patients are able to mobilize and get back to their normal activities of daily living and gradually improve without any formal physiotherapy being required. In situations where they've had severe osteoarthritis and they're quite stiff, they may have some balance problems or some muscle strength problems, physiotherapy is indicated. Patients are referred to a physiotherapy practice close to their home where travel is convenient, and if it's convenient, then they're more motivated to attend rather than driving for an hour or so. For knee replacements, the situation's a little more complicated because the recovery is a little longer, and the patients start a formal physiotherapy program 2 weeks after the surgery. By that stage, they're generally at home. And again, we choose a physiotherapy practice close to their home where commuting is easy. I chose orthopedic surgery as relatively late in my training program. Initially, I wanted to be an oncologist, and during my preparation towards the end of my medical school, getting ready for an oncology fellowship, I happened to travel to New York and spend some time at the Sloan Kettering Center in downtown New York. That gave me the opportunity to visit the Hospital for Special Surgery, and that was the first time I actually saw a joint replacement as an undergraduate at Sydney University. I had never seen a joint replacement, and that enthralled me. The surgical technique, the materials that were used, the mechanical aspect of the surgery. With further training and investigating that particular specialty further, the rapid recovery and the dramatic influence we have on people's lives, the instant, virtually instant gratification. As the doctor, you produce a dramatic change in the patient's lifestyle relatively quickly, and that's very satisfying. I was fortunate enough that at that stage, that was really the beginning of joint replacement surgery. And from the mid-1980s, the explosion in knowledge and material properties, the techniques, that was really the beginning of hip and knee joint replacement as a successful specialty. And I was very fortunate to be around when this technological development occurred. At the end of my training, after I finished my training in Sydney, I spent a year travelling through Europe. I spent time working with Paul Mackay in Belgium, who was one of the leaders in osteotomy treatment of the hip, and I learned a great deal about biomechanics from him. He was inspirational, and I owe him a lot. I spent, after that year, I spent a year in Cambridge working at the Addenbrooke's Hospital. I was fortunate enough to work with David Dandy, who is an outstanding surgeon. I visited Wrightington, where Sir John Charnley worked, also inspirational. And I had mentors in Sydney to whom I owe a great deal. Brian Casey, Bruce Shepherd was a great mentor and inspiration. Merv Cross, who I also worked with. These people affect your life, and their vision and focus, intellect, drive, determination were all affected me. I'm very grateful to these people who gave their time and shared their knowledge very freely. Joint replacement has come a long way. We need to remember that the first joint replacements were done in the 1940s, and Sir John Charnley really brought it into an effective patient treatment rather than an experimental technique. And at that stage, that was the first phase of joint replacement, and at that stage, pain relief was the goal. And if the hip joint dislocated, and if the leg was a little short, and if the joint didn't last too long, that was acceptable. And that was the first generation. Second generation was when it was expected that the legs would be equal length, that the joint would not dislocate. But if it didn't last for 40 years, it was expected that it would wear out. And if you weren't able to return to your normal activities, marathon running, skydiving, normal occupations, mining, farming, it was expected that you would not be able to do that. We are now in the third phase of treatment, where patients expect essentially normal function. They expect that the joint is going to last. They expect that they will be able to have pain-free function. But what's more, they expect to be able to return to their normal activities, playing sport, undertaking heavy physical work. This now requires a change in material properties. We have the surgical techniques. Anesthesia is developing very quickly. So in the future, I think the progress will depend on technological developments, material properties, ceramics, new materials, carbon fiber, those sort of things. Probably the thing that worries patients most is pain, what they're going to feel, and how we're going to look after it. We've developed a technique that addresses pain at the site of the operation. We call it local infiltration analgesia. And we use a combination of medications, but primarily a local anesthetic, similar to the one that the dentist uses, but a much longer lasting anesthetic. The aim of this is to address the pain where it's located, namely at the site of surgery, without having to treat patients with narcotics that cause nausea and confusion and generally make people feel ill, keep them in bed and keep them in hospital. By using this technique, local infiltration analgesia, we've been able to achieve a dramatic decrease in the level of pain that patients feel, to improve their mobility. By improving their mobility, By improving their mobility, the potential complications that can occur as a result of joint replacement surgery, such as blood clots, swelling, infections from having to stay in hospital for prolonged periods, those factors are minimized. By minimizing the pain, the patients feel uplifted and are able to return to their normal activities much more quickly. Once people return to their normal activities, in their mind, the treatment episode has finished and they're able to get on with the next phase of their life rather than being restricted in the post-operative recovery phase for a prolonged period of time. For more information in relation to anterior hip surgery, please visit us at anteriorhipsurgeonsydney.com or call us at 9387 2877. I met Andre and the Orthopaedic Media Group at the Orthopedics Today meeting in Hawaii. The product and process that he explained to me was innovative. It appealed to me as being at the cutting edge of not so much medical marketing, but really providing information for patients in a non-marketing way. Information that patients seek, and the patients troll the internet for information all the time, particularly medical information. And I was keen to modify my website not in a specifically marketing glitzy capacity, but more information-based and making it realistic so that patients would get to know me before having a physical encounter with me. Andre presented his product in a very realistic way, very little marketing. I was impressed by the process and the techniques that he used. I saw the work that he'd done previously for other doctors, and I felt it would suit my particular type of practice very well. I was impressed by the fact that he would be happy to travel all the way to Sydney. The whole process was easy to arrange. He's an easy person to work with. I would highly recommend him for this sort of work. I would highly recommend Andre and the Orthopaedic Media Group. They're a professional organization. They are highly organized, easy to work with. The organizational aspect from my end was very easy to arrange.
Okay, so here at the Joint Orthopaedic Centre, you're to bring a GP referral and a current X-ray of either your hip or your knee, which is no older than 3 months old. Here at the Joint Orthopaedic Centre, we get you to fill out a registration form. Here at the Joint Orthopaedic Centre, the consultation usually takes between 1 and 2 weeks to get an appointment. Here at the Joint Orthopaedic Centre, when you've decided that surgery is your only option, I'm the one that books the surgery for you. It takes roughly about 4 weeks from the time you see Professor Kohan till your surgery date. Okay. If you have any more questions or want any more information, please visit us on www.jointreconstruction.com or call us on 9387 2877. We look forward to hearing from you. Thank you for contacting us. The only thing that we do here, I don't know whether we want to tell them on the camera, is that at most, well, because I've worked for other orthopaedic surgeons, pre-admission is done in the hospital. Here it's done in our room. So they basically, once they've seen Professor Kohan, they book in surgery, then I book the surgery in them. But prior to having the surgery, they must make an appointment with me to see our anaesthetist who takes them through the whole operation. So basically, after you've made an appointment to have your operation, then I will make another appointment for you to see our anaesthetist who will take you through the whole operation.